All right, protocol 17, ventricular fibrillation and ventricular tachycardia adult. No real change from your current protocols except for your antiarrhythmic is no longer lidocaine, it is now amiodarone. ACLS procedures shall be followed in all cases of cardiac arrest. Just the notes here, again, at any time if we have ROSC, go to the post-resuscitative care protocol. Adequate ventilations and CPR are major buffer agents in cardiac arrest, and sodium bicarb is not recommended for routine use in cardiac arrest. And of course, we need to consider bilateral chest decompression in traumatic arrest. All right, so let's talk about amiodarone, one of our new drugs we're going to be carrying. For VFib pulseless VTAC, the initial dose of amiodarone is 300 milligrams IV-IO, and it can be repeated at 150 milligrams IV-IO if refractory. Now, refractory means obviously resistant to treatment. The way we're going to be carrying amiodarone is 150 milligrams in 3 mLs. Okay, so what is amiodarone? It is an antiarrhythmic. It's indicated in treatment of ventricular arrhythmias and atrial fibrillation. Actions is it prolongs the action potential duration in all cardiac tissue. Contraindications to administering amiodarone is cardiogenic shock, sinus node dysfunction resulting in marked bradycardia, symptomatic bradycardia, second or third degree AV blocks, and known hypersensitivity to the medication. Precautions are heart failure. Side effects are hypotension, bradycardia, increased ventricular beats, prolonged P to R, prolonged QRS complexes, and prolonged QT intervals. Dyspnea and cough. Amiodarone basically slows down the conduction in all aspects of the electricity in the heart. Okay, so for our intermediate and paramedic providers, if amiodarone converts your patient's lethal rhythm, we need to hang a maintenance infusion. And the dose of our amiodarone maintenance infusion is 1 milligram a minute. Now, to do this, we will mix 100 milligrams of amiodarone in 100 milliliters of D5W. Remember, the amiodarone is coming in a concentration of 100 milligrams in 3 mLs. So 2 mLs will be 100 milligrams. And of course, remember, reversing torsades de poids, mag sulfate is our drug of choice, and that is at 2 grams IV-IO. Protocol 18 is our VFib VTAC pediatric protocol. No real change in our treatment other than our chief antiarrhythmic is amiodarone. And the dose of amiodarone for our pediatric patients is 5 milligrams per kilogram IV-IO to a max of 300 milligrams. You may repeat 5 milligrams per kilogram in 5 minutes. Maximum subsequent doses of 150 milligrams and a maximum total dose of 15 milligrams per kilogram. So you may give your second dose twice. So an initial dose of 5 mg per kg, repeat dose of 5 milligrams per kilogram, and a repeat dose of 5 milligrams per kilogram. And also, to reverse torsades de poids in our pediatric patients is mag sulfate, and the dose is 50 milligrams per kilogram IV-IO, and you may repeat every 5 minutes to a maximum of 2 grams. If suspected hyperkalemia, diabetic ketoacidosis, or overdose of tricyclic antidepressants, aspirin, cocaine, or diphenhydramine, we want to administer sodium bicarbonate, 1 milliequivalent per kilogram IV-IO. Protocol 19 is our cold exposure protocol, and it's broke down between hypothermia and frostbite, whether or not it is localized cold injury or a systemic cold injury, and no real change from your treatment in your current protocols. Just some notes on Protocol 19. No patient is dead until warm and dead. Hypothermia is defined as 35 degrees Celsius or 95 degrees Fahrenheit. And hypothermia may produce severe bradycardia, so we need to take at least 45 seconds to palpate and locate that pulse. Also, active warming with hot packs. We want to consider withholding CPR if the patient has an organized rhythm or has other signs of life. Intubation can cause ventricular fibrillation, so it should be done gently by the most experienced provider. Now, if the patient's temperature is less than 86 degrees Fahrenheit or 30 degrees Celsius, only defibrillate one time if required. Below 30 degrees Celsius or 86 degrees Fahrenheit, we need to contact medical control before administering any antiarrhythmic medications. And also, if they're below 30 degrees Celsius or 86 degrees Fahrenheit, we need to contact medical control before pacing. Okay, protocol 20 is our heat exposure, heat stroke protocol. And this protocol really is a good reference for the provider. It breaks down the differences between heat cramps, heat exhaustion, and heat stroke. Okay, so in protocol 20 for heat exhaustion and heat stroke, our advanced through paramedic level providers are going to focus on maintaining a systolic blood pressure greater than 90 millimeters of mercury. We're going to do this by administering boluses, 500 mLs. And you can repeat up to a max of 2 liters. Of course, we're going to assess the patient for fluid overload while doing so. Just a note that sweating generally disappears at a body temperature of 104 degrees Fahrenheit or 40 degrees Celsius. And remember, we are treating a heat emergency due to environmental extremes, so the use of antipyretics are not indicated in this protocol. Predisposed to hypothermia, patients who take tricyclic antidepressants, patients who take antipsychotics such as phenothiazines, anticholinergic medications, patients who abuse alcohol, cocaine, salicylates, and amphetamine. And again, sweating generally disappears at 40 degrees Celsius or 100.4 degrees Fahrenheit. All right, heat cramps are not associated with elevated body temperature. Heat exhaustion vitals consist of tachycardia, hypotension, and elevated body temperature. Now, heat stroke vitals consist of the same tachycardia, hypotension, and elevated body temperature greater than 104 degrees Fahrenheit, as well as your patient will exhibit signs of altered mental status. Protocol 21 is our bites and envenomation on land protocol. It covers snake bites, spider bites, bees and wasps, dog, cat, and human bites, and no real change in your treatment from your current protocols. Protocol 22 is our burns protocol. It's broken down between minor burns, serious burns, and critical burns. Okay, so for Protocol 22 and our burns, our INP level providers will be administering nebulized epinephrine to patients who show signs of smoke inhalation and they're experiencing difficulty breathing. They're going to administer 2 milligrams of 1 to 1,000 mixed with 3 mLs of normal saline, and they're going to nebulize the epinephrine to the patient. Also within this protocol, there is the Parkland formula for patients with greater than 15% total body surface area burned, and this is a condensed Parkland formula, 0.25 milliliters per kilogram times the percentage of total body surface area burned. And this is the amount of fluid we're going to give per hour for the first 8 hours. Okay, just to talk about the PEARLS section in the burns protocol. Patients that require direct transport to a burn center or transfer once seen at a local facility where the patient can be stabilized are as follows. Greater than 5 to 15% total body surface area, second or third degree burns. Greater than 5% total body surface area, third degree burns for any age group. Any patient with circumferential burns. Electrical or lightning burns, suspicion of abuse or neglect, inhalation injuries, chemical burns, burns to face, hands, feet, perineum, and genitalia. Again, these are the patients that require direct transport to a burn center or transfer once seen at a local facility where they can be stabilized.